female, personal history, COPD, AFib, pulmonary access, COPD stage 3, diabetes, stage 2. Status was flat coli on week 10 with gangrenous gallbladder, no gram, developed reintubated, low hypotension, AKI fever, and she was yesterday. So, I guess for neurological wise, CT had negative yesterday, today on neuro exam, she follows. Nothing. But she's able to see these figures and breathing things outside. So it's a full improving.
Definitely not consistent.
Okay. Pulmonary perspective, history COPD over meds, CT, chest, yesterday, last night showed blue bilateral effusions and possible consolidations. We're going to repeat an x-ray today. For fluid is likely some pulmonary edema. Cardiac perspective. So she's been tachycardic. She has a history of AFib. This morning she definitely looked like irregular rhythm. EKG yesterday just showed sinus tach. Sinus tach. But she's currently not on her anticoagulation due to the recent surgery and question mark. So it looks like you ordered an echo this morning.
Yeah, I ordered it last night just to double check. We're missing something cardiac.
Okay.
Could have occurred perioperative.
Okay, yeah, that goes on the 9 on normal function.
So they may call on that because they could do just limited, but I want to look at RV function, LV function.
Yes. Okay. Sounds good. From pressure standpoint, so we gave albumin last night. She's also been running 75 ml per hour of LR, and she's been on norepi of 14 and steroids for pressors. She's been doing well on that.
Norepi up, down.
Been
14.
pretty consistent.
14. Okay. Still getting the bicarb drip.
She's still on bicarb drip. For renal perspective, she's no longer acidotic. pH was 7.37, bicarb was 22, C2 37. So we're going to stop the bicarb.
Yeah, we can just see. I would maybe just definitely check the gas later if it's bicarb might be normalizing that and sending the acute kidney injury.
EBG this afternoon.
Yeah, say noon, 2 o'clock, somewhere in between there.
Stop it and have a check it.
Yeah, and just see if she can maintain. Now that maybe she's a little bit better perfused and maybe better resuscitated.
Yeah. So their LR run last night. I guess since she came here, she was positive 2 liters. Like we received about 3 liters during transfer. She's urine outputs average at 36 mLs per hour this morning. A little bit down on urine output, but I think she's definitely going to be resuscitated. Creatinine is also going on 2.5. So I think my question: do we want to diurese?
I would probably just see where we're at again.
See how she does with the volume resuscitation.
We're not, our oxygenation isn't horrible, so we have room to push fluid from a pulmonary edema standpoint.
Which is not big, just 75 mLs.
Right, and if there's ATN related to hypoperfusion, then we want to wait to see whether that'll recover. If we see the creatinine peak, and then we start seeing it maybe come down, then that would be it. Or if we get to the point where creatinine continues to go up and urine output continues to fall before we would consider dialysis, then we would push for diuretics to see whether we could potentially get her to drink some urine. But I think right now I would just kind of like status quo, see what her creatinine does, see what her urine output does, see whether her blood pressure gets better.
Yeah, okay. Sounds good. So GI perspective, so I guess so likely septic shock. Currently looking for a source of infection. She was febrile before she came. So since we didn't do a gram, the question is, she having cholangitis?
Right, so without the intraoperative angiogram, the question, could she have some obstruction? The ultrasound of the liver didn't, I can't remember whether that was back before he left last night.
I think the vascular study was normal, total vein thrombosis. CT showed some fluid, blood versus bile. They're favoring blood, they said. Recommended either HIDA scan to rule out bile leak. So we could consult GI also to see what they think. If they want to do an ERCP.
Yeah, that's fine.
See what their thoughts are.
So you could order the HIDA just to make sure we don't have a biliary leak, which could be
Okay.
causing some peritonitis. You can
Yeah.
get GI on board to see whether ERCP or MRCP would be warranted.
Okay. So as far as anticoagulation, since it's a possible blood grab, I'm keep holding.
I put her on heparin sub-Q just for DVT prophylaxis today. We
Okay.
can hold on the full dose anticoagulation until we decide are there going to be any major procedures done or anything like that.
Okay. Okay, she's on cefepime and metronidazole.
Yep. Cover for anaerobes, which is
Cefepime.
reasonable. Cefepime should cover all our gram-negative intra-abdominal stuff for the most part.
Yeah.
So the only other option would be switch her to something like ertapenem or meropenem, which may cover more of the GI bugs with one antibiotic, but we can hold on that till cultures come back. So.
Okay.
Just gonna look at the pure stuff real quick. Culture, see if anything came back.
The CT was questioning pancreatitis or lipase was normal. You could repeat it.
Blood cultures from peer from 810 are no growth to date. Urine culture is still pending. So to summarize that, I think GI consult, HIDA scan, continuing IV fluids, DC bicarb, repeats in labs this afternoon, maybe a ABG and a BMP, see where creatinine and our lights are at off the bicarb drip.
Yep.
And then wait and see what GI has to say about ERCP versus MRCP. And
Yeah. Okay.
so the short discussion is things are relatively stable from yesterday. They're not dramatically worse. Some things are a little better, some things are stable, some things are a little worse, like the kidney functions. Creatinine's risen a little bit, but she's still making urine, which is a good sign. So just got to kind of let her body calm down and heal from whatever's going on in there and continue to support it. Questions or concerns?
MRCP versus
MRI, where you go
Oh.
for the MRI to look at the biliary tree to
Yep.
see whether there's any stone versus
Stones, yeah.
ERCP, where they would take a scope and go through down the esophagus and look that way. So
Okay.
neither one of them are maybe outstanding options just because she's on pressors to keep her blood pressure up, so she's sick enough for that. So the GI doctors may not be super excited about doing an
Yeah,
invasive
yeah.
procedure on her and then sending her out of the ICU with low blood pressure for an MRI for 45 minutes isn't ideal either. So
Yeah.
we'll see what the GI doctors have to say, and they may just say, well, let's just drag our feet for a while, or they may say, yeah, we got to do something. But,
Okay.
and then when they put clips around the biliary tree per se, where the gallbladder drains from the liver and the pancreas and everything come in, sometimes there can be a leak from that area, and so that sometimes can cause some inflammatory changes too. So that's what the HIDA scan is, to look and see what's going on there. So, well, that can be done right here at bedside. So.
Okay. What was the other way they look at the bile duct?
Oh, so they could do a cholangiogram, which they sometimes do in the operating room.
Yeah. You said you didn't think you got time.
Yeah. So that's how what the ERCP and the MRCP would help us do. There would be other ways to look through the biliary ducts to see whether there's any residual stones that could be obstructing. if I remember correctly.
You have to remove them mechanically then?
Yeah, so if the MRCP was positive, that would result in an ERCP.
Yeah.
They would go in and take that duct and open that up, and then they would put a stent in there to see if they could get that sludge debris or any stones or anything. Maybe be able to mechanically even go in and pull out a stone to get rid of some obstruction. So. Yes.
We just talked about the ketone level.
Yeah.
4.2. I don't know if you want to call it true DKA or not.
Well, so I mean, we potentially could. I mean, there's probably a lot of reasons why she could have ketones. The problem is that she's not really a type 1 diabetic, so the likelihood of this being a true DKA is less likely. The question is could she have DKA or the ketone from starvation or other? I know they were quite high, but treatment for that would obviously be insulin, which we're on. So.
It looks like someone's PIC where you already start her on the
Yeah, I can't remember if I did that before I left last night, as I, was going through the chart, or whether they did that. But blood sugars were in the high 200s. We were adding steroids. We were adding the D5W. So I think I started Endotool before when I started the bicarb last night after ABGs came back. So I think we'll just trend her blood sugars and see whether the ketoacidosis was part of her acidosis. So the good thing is her liver tests are improving compared to yesterday. They're coming down. Bilirubin's coming down. Alk-Phos is up a little bit, but kind of variable. But that would go less against the continued obstruction there.
Yeah.
So we'll see what the test shows. Any other concerns? Any pharmacy concerns?
Can we recheck her potassium when we do the repeat ABG?
Yep. We'll order a BMP to see where crap is.
Okay, awesome. And then I was just wondering, with her being hypertensive and tachycardic, do you think Neo would be a better option for her right now? To optimize hemodynamics, or?
Potentially, it's just I worry about septic shock and the need for beta and unopposed alpha. She's in sinus tachycardia. Something to definitely consider, but I don't know. I'll take a look at it. Any other concerns?
What's the HIDA scan, like medicine is doing shortage?
I'm sorry.
HIDA scan, I think I tried to order a HIDA scan earlier, but they said that we're in a shortage of equipment, so would that still the issue, or?
I would have no idea.
Yeah.
That would be
If
a
we order it and they say
radiology
no, then we can
question.
talk with GI and see what the best test to order is.
Yeah, they manage the contrast and all the nuclear stuff. So.
Nutrition on hold still.
Yeah.
So we'll wait to see what IDA and everything shows.
As I say, I mean, you just want to wait off until
Yeah.
GI.
Yeah, but I think if GI says she can undergo a scope or doesn't need a scope or anything like that, and the height is done and she doesn't have to be NPO, then we can start some trophic feeds on her and see how she tolerates it.
Okay, I'll just check back with them.
Okay. Anything from anybody else? All right, well, thank you for your time.
Yeah, thanks.
Thank you guys
Yeah,
very
appreciate
much.
it.